Well, good afternoon. Coming to you straight from the home of Mrs. Cook. We are going to have class and cocoa with my little pretty monkey nurse. Do you see it? Yeah. Okay then. Don't be surprised if my cat crawls up into my lap soon. So it's class with Cook, Coco, and Cat. All right, so I've lost my mind. I'm sure that you're probably right along the same line that I am. But anyway, um, just wanted to go over the next PowerPoints. I do believe this may be the last one that I'll do, and then Miss Chapman will take over. But you never know. You might see me again, or you might not. Um, Anyways, we're going to talk about pregnancy-related complications in class. What I want you to understand here is that there are actually um, probably most of the information that you're going to need for both this week and next week is included in this PowerPoint. So just know that and distribute the information appropriately because some of it, I can't remember exactly, but some of it may be on quiz 2 and some of it may be on quiz 3. But it's all included in this PowerPoint. Okay? Here, let me sip my cocoa. Ah, so good. It's that junior mint hot cocoa. It's just yummy. Feel free to put your feet up and get some cocoa too. All right. One of the things that is, uh, I don't want to say it's common as in it happens with every pregnancy, but it is fairly common, and that is pregnancy-induced hypertension. It's been called a number of things, and depending on, what generation you're from, if you or still it's still referred to as um, toxemia, preeclampsia, and really the proper name for it nowadays is gestational hypertension. So pregnancy-induced hypertension, you'll still hear it used. Sometimes you'll still hear toxemia and preeclampsia used, but the official name now is gestational hypertension. And this is a blood pressure elevation after 20 weeks of pregnancy. And it may progress and get worse and worse and worse throughout the pregnancy. So as the nurse, you're going to want to monitor that blood pressure. The thing with a gestational hypertension is that sometimes it can show up after delivery. Now, I've seen this. I don't want to say quite a few times, but I've seen it a few times. And the woman has had no evidence of hypertension before delivery, but all of a sudden, after delivery, you'll begin to see a problem with blood pressure. Preeclampsia, the systolic blood pressure will be greater than 140, and the diastolic blood pressure will be greater than 90. And there's significant protein in the urine, and edema is not a specific indicator. They used to think that once edema started occurring, that the woman was probably becoming uh, having a pregnancy-induced hypertension, but that alone is not the case because many women have some edema in their ankles while they are pregnant. But when you combine the higher blood pressure and protein in the urine and edema, then it becomes kind of a triad of symptoms that need to be looked at closer. With eclampsia, that's when, because the eclampsia itself means seizures. Preeclampsia means that condition before seizures. So eclampsia is when you have these generalized seizures and they can continue into postpartum. So it's a very serious complication of pregnancy. Now, that is not to be mistaken with chronic hypertension. With chronic hypertension, the woman comes into the pregnancy with hypertension, and it won't resolve after delivery. So whereas with pregnancy-induced hypertension, usually the hypertension will resolve once the baby is born, because the only cure for gestational hypertension or preeclampsia is the delivery of the baby. And once that's done, mom can go back to normal pretty soon. And chronic hypertension, of course, as I said, will be there at the beginning of the pregnancy. And of course, you're going to see that before that 20-week mark. Whereas with gestational hypertension, you're going to see it after the 20-week mark. So when you're doing assessments on a pregnant woman with pregnancy-induced hypertension, you're going to want to do daily weights. And the reason for that is, and this is when you really have determined that a pregnant lady has pregnancy-induced hypertension, because those daily weights will determine how much fluid she's actually keeping. Take the blood pressure at the same time of day, in the same arm, and in the same position, so that, any position, positions can alter blood pressures. So we want to make sure that we're doing it consistently every time. All vital signs, breath sounds. When it gets really bad, sometimes you're going to hear some uh, maybe some crackling or gurgling. Deep vein reflexes are important, as PIH, pregnancy-induced hypertension, preeclampsia, as it progresses, deep tendon reflexes can become very hyperreflexic. In other words, you do the patellar reflex, and the leg will respond very, very well. It will really kick out. Now, some of us have hyperreflexia anyway. I know that if somebody, tapped my knee, my leg would fly out and, kick the ceiling or something. But this is, for a woman with a PIH, you really want to pay attention to that hyperreflexia. Urine output, your may or may not be increased. Urinary protein, as it progresses, as PAH progresses, you're going to notice that there's more protein in the urine. Level of consciousness can change, and headache. And when it gets really, really bad, all right, that headache is severe, you're going to have epigastric pain and visual problems. Also, when we talk about that edema, it's not just edema in those ankles. It can be in the hands and something called periorbital edema. So when you start seeing the face swelling, we've got a real serious problem when it comes to pregnancy-induced hypertension. Here is a link that I would like for you to view. I always like for you to see things said a different way by different people, because just because I say it in a certain way doesn't mean that, oh, yes, Miss Cook has spoken, everything is clear. Sometimes when you listen to something that somebody else says about the same subject, it can clarify some things. So please, please, please watch this PIH link that I've embedded into this PowerPoint. For right now, we're going to go on. HELP is what happens as PAH continues on and becomes worse and worse and worse. And this is where, and HELP is actually a sort of a mnemonic to help you to remember what kinds of labs will occur. But H stands for hemolysis. In other words, the red blood cells are going to begin to break down. Of course, that's bad because red blood cells carry oxygen. EL stands for elevated liver enzymes. So again, you're going to have to look at those liver enzymes. And especially, you're going to get some of these lab values for every pregnant woman, but when you're talking about somebody with PIH, gestational hypertension, whatever you want to call it, you're going to want to pay close attention to these labs because they may become elevated or gradually become elevated. And remember, well, you haven't had me a lot, but I believe in trends. So you never look at one single lab result. You want to look at lab results over a period of time because you can have a high lab result, but in 3 days, that lab result can still be high, but it's lower than it was. So you can see that some progress is being made. The same way holds true here. If a woman has elevated liver enzymes, even if they're almost elevated, but you continue to see something going up, then you know that it's becoming a worse and worse problem. And then low platelets. And when I talk about low platelets, the low end is 150,000, but low platelets can be, these ladies can go down to, like 60,000 or 50,000. And that really, that's a big problem. Now, we've got other clotting factors at work during pregnancy. However, when a woman's platelets are, you know, 50,000, then there's a real risk for her to bleed. Um, Again, I've already mentioned the epigastric pain, periorbital edema, and liver distension. And there could be nausea and vomiting, seizures, and then DIC, disseminated intravascular coagulation, which is a real complicated process that we'll talk about in a few minutes. And as I've already said, it can manifest itself in postpartum. Um, and I've seen that happen. So, keep your eyes open for it if you ever become a postpartum nurse, because it can happen after the delivery of the baby. Once again, I've got a wonderful little help link here for you. Please look at that. I don't need for you to do it unless you want to. You can do whatever you want to do with this PowerPoint because you have full control. But do please, I really hunted for these links to help you with your understanding. So it's not just a little extra piece of information that you need to have in terms of just taking up your time. They really are truly helpful. So please watch that. So here we get to DIC, and this is kind of what happens. This is a progressive kind of thing because you start out with PIH or gestational hypertension. Then it becomes worse and worse and worse. You develop that HELP syndrome. And the worst thing that can happen is it can evolve into this DIC. So HELP is that predecessor to DIC. So when you get to the place where mom has developed that HELP syndrome, you really have a problem. It's both a clotting and a bleeding disorder because it starts with clotting, and all of those clotting factors get used up very, very quickly, and then you've got these low platelets, and so the clotting factors are used up. There's no backup in terms of clotting factors uh, when we talk platelets, and then all of a sudden you've got bleeding. Now this bleeding can manifest itself as oozing from wounds, nosebleeds. Worst case scenario, you've got blood coming out of your ears. Um, but it's a very serious thing, and of course, it's deadly if it's not dealt with quickly. Some of the risk factors, and please listen very, very carefully as I go through these risk factors because they are relevant, and you will see these as questions in the future. But some of the risk factors that are included in this whole DIC in pregnancy are an abruption. So somebody that has abruption of the placenta, and I'm going to talk about that a little bit later in this video, um, is more likely to have DIC. Somebody with PIH, preeclampsia HELP, is more likely to have DIC. It doesn't mean that they will, but it puts them at risk for DIC. Fetal death, all right? If there has been a fetal death, that puts them at a higher risk for DIC. If there is an amniotic fluid embolism, higher risk for DIC. A septic abortion, where the baby has died, there's some kind of infection, that mother delivers, and it puts her at risk, higher risk for DIC. So some clinical manifestations of DIC are bleeding, obviously, ecchymosis or little spots, red spots, mucosal oozing. Mucosa, is found in the eyes, the nose, the genital areas. So anywhere that you've got a mucosal um, opening or uh, surface, you are more likely to have bleeding. And again, here we have the GI bleeding, bleeding from incision sites, an altered mental status. And of course, that comes with the fact that, you're losing blood, therefore oxygen to the brain, and that can cause that altered mental status. Also, blood loss can eventually lead to organ failure. So we're talking about a very serious series of events, and this does happen. Thankfully, HELP and DIC doesn't happen as often. PIH, however, can happen, and that's why it's so important to be familiar with these signs and symptoms so that we can intervene before it gets all the way to DIC. Therapeutic management includes hospitalization immediately. You always want to check that fetal status, and of course, we do that with fetal monitoring. Also, checking on the maternal cardiovascular status, and that, of course, includes that blood pressure and vital signs. Conservative management is rare. In other words, they're not going to sit back and wait to see what happens. They're going to get on it. Tocolytic medications will be given, and also the Rh negative mother is going to be given RhoGAM, because when there's DIC, there's a possibility of the baby's blood and the mom's blood mixing, you know, uh, maybe. And as a result, they want to make sure that the mom um, doesn't develop antibodies that can be transferred to the baby. Normally, the blood from the baby and the blood from the mom do not mix. But in an incident like DIC, we just don't know that they won't mix. So they will give that RhoGAM to mom, in the event that, and it probably has been given already anyway, but they will give it to make sure that if any of those antibodies that have developed as a result of the baby's blood mixing with mom's blood, that they won't be transferred back to the baby, because those antibodies will actually kill the red blood cells in the baby's body. And that's when you have like a pathologic jaundice. Not the regular jaundice that you see after a baby is born, but like a real jaundice, as in the baby's probably going to need a transfusion kind of jaundice. As far as the nursing assessment goes, observe and interview, examine, observe, interview, examine. Things can change very quickly. I had an experience when I first started out in labor and delivery where I thought, oh gee, we were in report. Actually, this is how it happened. Let me have a sip. We were in report, and there was a lady there who was pregnant with triplets, and had also developed some um, PIH and some other things. Anyway, I said, "Oh, great experience! I'll do it." Well, I never would imagine what I got myself into. So I received report from the nurse, and the nurse told me that the patient was stable, and that, went on. And I thought, okay, great, patient stable, no worries about getting these triplets delivered, good to go. So I had to, and this is lesson. this is a good lesson right here. Don't ever count on somebody's report to determine what is actually going on with that patient, because when I went in to assess the patient and I assessed her reflexes, there were no reflexes. Now, why? Because I just told you that with PIH or preeclampsia, that reflexes will be overactive. In this case, she had had magnesium sulfate, and you guys did a med card on magnesium sulfate. And that's why I had to do the med card. Was at this point I can explain more. You know, that magnesium sulfate kind of calms everything down. Contractions, blood pressure, the whole deal. Well, it can calm somebody down so much that they have difficulty breathing. And so this is what was happening in this mom. She did not have any reflexes. I'd left the room. I did my documentation, and then I got a message from mom or from dad that mom was having trouble breathing, which meant that whole process of the magnesium, she probably was becoming toxic. And as you reviewed that magnesium sulfate, you probably documented somewhere, or at least referred to it, that you can develop magnesium sulfate toxicity. And there is only one way to reverse the effects of magnesium sulfate, and that is to give calcium gluconate. So the doctor was called. I had to give the woman calcium gluconate, and the contractions immediately started, and they immediately come back to life. It's like they are really groggy, they're out of it. It's, horrible. But as you push that calcium gluconate in, you can see them literally coming right back to life, like, oh, everything's fine now. So what ended up happening in that situation was we ended up delivering those, I think they were like 24 weeks. We ended up delivering those triplets later on that night. Because of DIC, there may be a need for a blood transfusion. Of course, oxygen therapy, pain control, lots of teaching. Of course, when the mother can hear the teaching, of course, the significant other or the person that's assisting the mother during the labor will need some teaching, and of course, fears being allayed will be very, very important. Always assess the pulses. This is going to be like an ongoing, like every 5 minutes kind of thing. Provide warmth, check the capillary refill, make sure, in other words, we'll make sure that she's getting perfused by the oxygen that she needs, monitor those labs, and of course, again, manage that pain. Oops, let me go back. I said go back. All right, I don't know if it's going to actually let me do that. So um, the last slide again was a wonderful little video I found on DIC. Keep in mind, please, please, please watch these little links that I've provided, because they totally, um, they totally like fill in places, kind of cement the knowledge process, so that when you walk away, you have a better idea of what all this stuff is going on. Now, placenta preview. Remember, I said that this video or this PowerPoint will flow over into another week. So please pay attention to the messages that I give to you, because I believe, if I'm not mistaken, because I had to break it down and then I broke it down again and then I put some pieces back together. But you probably will see placenta previa and abruption on a different quiz than you will see the PIH, the DIC, and the HELP. Okay, so just be aware of that. Come back, watch this again. Remember, you will have a final. So all of this will be relevant information. All right, so with placenta previa, we're talking about, this is the wall of the uterus. All right, I gotta get this. Yeah. And then here's the placenta attached. Okay. Sometimes that placenta will be attached over the opening, um, out of the uterus. So in other words, it's covering the cervix. The baby cannot be delivered if the placenta is covering the cervix. Sometimes it's just marginal. Sometimes early in pregnancy it will be marginal, but as the placenta grows and the baby grows, the placenta kind of migrates up the side of the uterus and never really becomes a problem in terms of delivery. Um, but again, that total previa is when the placenta will actually cover the entire opening. Incidence 1 in 200 to 300 births, not terrible, but it's definitely something to pay attention to. Usually happens in older women, or more likely to happen in multiparas. In other words, the more a woman with more pregnancies. Vaginal birth after cesarean, that's VBAC. Asian and African American people. Substance abuse, and the fetus is a male. Why, you little boogers. Um, but these are all risk factors, I guess, if you will, to developing a placenta previa. Signs and symptoms. Now, here's a slide to pay attention to. When you're talking about a previa, there's a sudden onset of painless bleeding, all right, due to some separation, because you've got that little previa down there. It's over the cervix. The cervix might dilate a little bit or efface, and as a result, there may be a little separation. Nothing to really worry about unless it continues to get worse and worse. But it will be painless bleeding, and I say that because that's unlike an abruption where there will be painful bleeding. It usually will happen in the latter half of pregnancy. When there is a preview, you want to avoid any kind of manual examination, because what you're doing is when you are vaginally doing a vaginal exam on a woman, you're actually going up and you can manipulate that placenta to the point where it could separate, and that causes a whole different problem. They may do some transvaginal um, ultrasound to confirm that there is a previa, and of course, even that they're going to want to be very careful. Interventions are based on the condition of the baby and the mom. If mom and baby are both tolerating everything well, then it's just watchful waiting. Hemorrhage, we need to look at how much the mother is bleeding. We want to electronically monitor the fetus to make sure that the fetus um, is not suffering from anything that might be going on in terms of the placenta. Women can be cared for at home, simply by maintaining bed rest. Probably they would only be allowed to do this if they were a reasonable distance from the hospital, and that transportation is available 24/7, and that they understand the risks of staying at home. So, it really depends on, what's going on with the mom in terms of what her availability is or how comfortable she is with not being in the hospital. But she also needs to understand that not being in the hospital means that there are some other things that can develop that won't be readily, nobody will be readily able to address those needs. So again, this is Larissa and Jennifer right there. You don't know them. They were actually going to, in another class a long time ago, they were going to talk about those things. But in this case, it's just us, and we'll be talking about them. So monitor any bleeding that is occurring. Is it getting worse? Is it getting better? Count fetal movements. How many fetal movements are there in an hour or however long the provider has designated? And then assess uterine activity and omit any sexual activity. Obviously, we don't need anything poking around up there. All right. As far as inpatient care goes, this is a woman that is not going to be able to meet the criteria for home care, so they will keep her. They will do a non-stress test, which we've talked about in a prior PowerPoint. They may do a biophysical profile, and they may do a cesarean if the woman becomes unstable or the baby becomes unstable. Again, I provided you a link. Please, 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 please watch this link. I actually will be giving you some updates on some of these links, as I believe that there are a couple of quizzes that will be required, and you'll send them to me. I'll get back to you on that. It's possible that you won't have to send me anything unless I need documentation that you participated in the class. Just like me, you've got to prove to me that you're with me, and I actually have to prove that I'm working now from home and actually document all of the time that I'm doing whatever. So while I'm here with you, I'm using time to make sure I legitimately am not spending my time watching the Hallmark Channel, which I absolutely love. No Hallmark Channel for me. All right, so here comes another placenta problem. And this is when the placenta either partially or completely separates from the wall of the uterus. This is bad and this is before the baby is born, let me add, because this is, if this were to happen, the fetus is no longer getting any oxygen. And of course, that will lead to the death of the fetus. Sometimes the abruption will happen in the center of the placenta, so that the outside borders of the placenta are still connected to the wall of the uterus, and a little hematoma will actually be forming on the inside. That hematoma is still bleeding, all right? It's just that it's not bleeding that you can see exiting the body. Risk factors: hypertension, smoking, malta gravida, abdominal trauma, history of having an abruption, or substance abuse. So all of these, a lot of people smoke, a lot of moms smoke. We need to make sure that we are educating those mothers that will leads them to having a higher risk for an abruption. There are 5 classic signs. Very, very important slide. Vaginal bleeding may not reflect that true amount, remember, because that hematoma can be collecting that blood up next to the uterus, or excuse me, up next to the placenta, and you aren't necessarily going to see all of it. There's going to be low back and abdominal pain. It is often sudden and it is severe. So we're not talking about necessarily, okay? Because remember, it's never always or never. But sometimes it may not be sudden, but it's going to get worse and worse, and it's not like a contraction. It's like the pain comes and stays. So you really shouldn't confuse it with labor, because it's not the same kind of pain. Contractions come incrementally, whereas if you have pain from an abruption, it's going to come and it's going to stay. Uterine irritability, high uterine resting tone. In other words, that uterus never really completely relaxes. It stays almost in a contracted state, sometimes in what we call a board-like state. So remember that word, board-like. And then uterine tenderness, obviously, with all of that going on. If you were to palpate the uterus at all, which you aren't going to want to do very aggressively at any rate, there's going to be some irritability. It's going to react to anything. It can lead to a non-reassuring fetal heart rate, hypovolemic shock, obviously, if the mom bleeds a lot, fetal death, and maternal death. Which brings me to a question. Who do you save first, the baby or the mother? Think about it, think about it, think about it. Well, the answer is they will save the mother before they save the baby. No, that's a hard pill to swallow for some people, but that is the protocol. You save the mother first, and then, if possible, you save the baby. Another little link here. Please, please pay attention to this. Always good information here. A couple of different ways. You're more likely to remember the information. It's more likely to make sense to you. I totally believe in, and I'm certainly not the be all know all of all things, and some of you may learn differently about certain things than or from different people. And the point is that I just want you to learn. And of course, I'll be available for any questions that you may have as well. Um, so just a nice little NCLEX question, which is always good to practice. Check out those NCLEX questions every time you get a chance, because they will truly, truly help in terms of um, in terms of your success on your on taking the NCLEX exam eventually. So, which of the following would nurse Sandra most likely expect to find when assessing a pregnant client with an abruption of the placenta? A. Excessive vaginal bleeding, rigid board-like abdomen, titanic uterine contractions, or premature rupture of membranes. So we're going to start with D and move up. There really shouldn't there's no real reason why an abruption would cause a rupture of membranes. Now, you may see a rupture of membranes, but that would not be the most likely, look up there at those words, most likely thing that you would see. You could have premature rupture of membranes with anything. Titanic uterine contractions. Remember, I said that these are not contractions. This is like this is uh, a board-like abdomen. I just gave it away. A board-like abdomen um, that stays board-like. It's not like a contraction that comes and goes. So yes, rigid board-like abdomen is the answer. And excessive vaginal bleeding, it may or it may not be, because remember, there could be a hematoma where you're not necessarily it's not going to, the bleeding that you see doesn't necessarily reflect the bleeding that is actually occurring. So, most common assessment finding in a client with an abruption is a rigid or board-like abdomen, pain, usually reported as a sharp stabbing sensation high in the uterine fundus, so it's at the top of the uterus, with the initial separation. Also is common. I'm not sure. Forget that also is common, because I must have been thinking something, but I can't remember what it was. So that could be confusing. Okay, I believe that that is the last slide. Guys, remember, I want you to email me. I want you to email me and just say, how you doing, Mrs. Cook? Or, guess what I think about it? And also pay attention to the discussion boards. And I will email you to keep you up. I think a lot of people emailed me and said it would be helpful if I emailed them on a continuous basis Just because there are so many moving parts, I understand that. Believe me, I do, because there are many moving parts on my side as well, and I'm sure I'm not keeping up with all of them very well. But we're all going to do our best. We're all going to hang in there, and we're going to do what we need to do, and that's all we can do. So, uh, email me. I would say text me, but you can't have my telephone number. Email me, discussion board me. We'll get it all worked out, people. Until the next time, goodbye.